Hello.
Hello, can you hear
Yes,
me?
sir.
Yeah,
Yes, sir. The room is open for the attendees. You can start the session.
yeah, in just 2 minutes I'll start. Okay, thank you.
Okay, sir.
Okay. Good evening to all of you. We'll start this session today. Today I got 2, 3 challenging cases and one short case to begin with. I will share my screen. Is my screen seen?
Yes, sir.
Okay. So this is a very ultra short case. It's a story of a 50-year-old man. He gave history of trauma to the left eye 1 year back. The story is like that. This happened when he was traveling in a car and was looking into the laptop. So the car suddenly braked, he went down and struck against the laptop. That is the story he gave. Since then, he noticed binocular vertical diplopia, looking down and to the left side. It improved partially, but the diplopia is still persisting even now, even after 1 year. So that's the story of the patient. So he had a head trauma on the left side, that's according to him, then followed by diplopia, vertical, which is more on looking down onto the left side. And this is how he saw the images on the when he has shown a line on the left side. One line is straight, the other line is tilted and going and tapering towards the right side. So from this history and findings, what do you think is which muscle is likely to be affected?
So right superior oblique.
Very good. So this is the
Right
typical,
superior oblique.
right superior oblique. Now, when the person is superior oblique, when you show the line below on the right side or left side, you find one line straight, the other one tilted, which is the tilted image belongs to the eye which is affected. And if that line is pointing, the arrow is pointing to the right side, it is right superior oblique. The arrow is pointing to the left side, it is left superior oblique. So this picture was very much like a right superior oblique palsy. Okay, now let us see what the examination findings in this patient. Okay, എൻ്റെ വിരലിൽ നോക്കേ വിരലിൽ തന്നെ നോക്കണം കേട്ടോ വേറെ എവിടെയും നോക്കല്ലേ വേറെ സൈഡിലൊക്കെ ഇടത്തോട്ട് നോക്ക് അങ്ങനെ നോക്കി ഇടത്തോട്ട് നോക്കണേ സ്ട്രെയിറ്റ് ലെഫ്റ്റോട്ട് നോക്ക് അങ്ങനെ ഇടത്തോട്ട് നോക്ക് ഇനി ഇടത്തോട്ടും താഴോട്ടും നോക്കിക്കേ ആദ്യത്തെ തന്നെ അങ്ങനെ നോക്കിക്കോ അങ്ങനെ നോക്കിക്കൊണ്ടിരിക്കേ ഇപ്പം രണ്ടായിട്ട് കാണുന്നത് അല്ലേ ഓക്കെ ഇനി നേരെ താഴെ നോക്ക് ഡയറക്റ്റ് താഴെ നോക്ക് ഓക്കെ ഇനി വലത്തോട്ടും താഴോട്ടും നോക്കിക്കേ കറക്റ്റ് ഇനി മുകളിലോട്ട് നോക്ക് ഇനി അപ്പ് ആൻഡ് ഔട്ട് നോക്ക് അത് തന്നെ ഔട്ട് നോക്ക് ഇനി നേരെ മുകളിലോട്ട് നോക്ക് കറക്റ്റ് ഇനി ലെഫ്റ്റ് അപ്പ് നോക്ക് ലെഫ്റ്റ് അപ്പ് ആൻഡ് ഔട്ട് അത് തന്നെ ഇനി സ്ട്രെയിറ്റ് ലെഫ്റ്റ് ഇനി ലെഫ്റ്റ് ആൻഡ് ഡൗൺ അത് തന്നെ കറക്റ്റ് എൻ്റെ വിരലിൽ നോക്കേ അപ്പ് ആൻഡ് ഔട്ട് നോക്ക് അത് തന്നെ ഇനി സ്ട്രെയിറ്റ് ലെഫ്റ്റ് ഇനി ലെഫ്റ്റ് ആൻഡ് ഡൗൺ അത് തന്നെ കറക്റ്റ് ഇനി സ്ട്രെയിറ്റ് ഡൗൺ ഇനി റൈറ്റ് ആൻഡ് ഡൗൺ, റൈറ്റ് ആൻഡ് ഡൗൺ അങ്ങനെ. ഇനി എക്സാക്ട്ലി ടു ദി റൈറ്റ്, ഇനി അപ്പ് ആൻഡ് ടു ദി റൈറ്റ്.
The video is not seen, sir.
Straight up.
Now it is seen.
It is not
Now it's
seen.
seen. Now
Okay, I'll show it once
now
again.
it's seen.
Okay. So, which muscle is affected according to you after the video? I'll show the offending position once again. It is maximum diplopia. This is the position in which is having the diplopia maximum. Pardon?
It is not right.
Right superior oblique also.
Right, do you think it's
No
right?
voice is not heard.
Pardon? Is it right superior oblique?
Left inferior, left
It
inferior
is not
rectus.
right superior oblique.
Correct.
Left inferior rectus is no.
So this looks like left inferior rectus. See, if you compare to the right and left eye is up, right eye is down. If it had been right superior oblique, the right should have been up. Okay, here right eye is down. That means superior oblique is acting very well. But the left inferior rectus is underacting. So in fact, the yoke muscle is the left inferior rectus and the right superior oblique. So either weakness of either muscle produce diplopia maximum looking to the down and to the left side. It is a position of the eye which matters, which tells you whether the superior oblique is affected or inferior rectus is affected. If it's inferior rectus was the culprit, that eye, left eye should have been up, should be up. If right superior oblique is affected, the right eye should be up. Here it is a left superior oblique, sorry, it is inferior rectus, left eye is up, suggesting is left inferior rectus weakness. Correct? Agree with me? See this one, you can see very clear. Yeah.
Yes, sir.
Yes, sir.
Correct. So this is very clear, no? Yeah, the right eye is down, left eye is up. Then how to explain this particular arrow, which is seen here? Now this can occur with either one side superior oblique or condylateral inferior rectus. I will explain that, then you will be easy to understand. Let us imagine this particular patient has got a right superior oblique. That is the one which is showing here. Why that line below has gone toward up and out? The arrow is pointing to the right side. See, right superior oblique is an intortor, correct? Right. When that intortor is weak, affected, what will happen? That eye goes into extortion. So the right eye, I'm talking not about a present patient, a person with the right superior oblique, how the image is created like that. So the right eye is superior oblique being an intortor. When that is paralyzed, the right eye goes into extortion. When the right eye goes into extortion, the image which is seen in the right eye is the opposite direction. It is toward it, that image is intorted. That means the first images which is seen here is intorted onto the as far as right eye is concerned. See, it's moving towards the pointing towards right side. Okay, that is why he has got a arrow pointing to the right side superior oblique parts. Is it clear to you? Am I audible or some problem in hearing?
Sir, can you please explain once again?
Yeah, I'll explain.
Your voice is breaking, sir. In between is going off.
Okay, some problem in the connection. Okay, I will tell you once. Please let me know if you are not able to
Voice
hear.
is very clear.
Okay. Now, so as I said, it goes in between. And I also find the internet connection is unstable in between. Now, I'll tell you, explain correctly. The one which is straight away horizontal is the image formed by the normal eye, or the normal eye. The right one below belongs to the false eye or the affected eye.
Now it's again breaking. The voice is breaking.
Okay. Do one thing, shall I?
No, sir. Sir's voice is very clear.
Yeah, it's very clear actually. I think.
Now it's stuck,
It's very,
sir.
very
Now the
clear.
video and voice is stuck.
No, everything is clear and video is running.
It's clear. It's clear.
Also, it is quite clear.
Okay, probably.
Sir, it's very clear,
joy,
sir.
Yeah, joy is this thing. Okay, what happens is that why that image is tilted towards the left side and pointing towards the right side, right up and out, is because The image on the right eye, which is falling on the right eye, that is the image of the affected superior oblique, is the one which is called the image, the line below that. What happens, the right superior oblique is an indautor. Okay. When that muscle is paralyzed, the eye goes into extorsion. So the eye is rotating outward on the right side. Imagine your right eye outside. But that eye sees an image in the opposite direction. Okay. Whenever you see when the eye is up, the image is down like that. When you see an image, the eye is extorted, the image is indauted. The eye is indauted, the image is extorted because its axis is in the middle of the thing when it falls on the retina. So the false image appears indauted as like this. So the arrow is pointing to the right side. Now it's clear to you why it is so? Because the line is indauted because the eye is extorted. Okay.
Sir, where is the arrow in this diagram, sir? I can't find the arrow.
The arrow is toward this side. This is the arrow. Okay. This is the arrow. One is it is pointing towards approaching to that side. I think I'll show it just after that. I will show you the superior oblique picture of his arrow forms. No, this one is
Arrowhead, it is arrowhead, sir. Arrowhead.
Arrow is forming towards the right side. Here, because the lower one, if extend upward, the arrow will come to the right side. From US view, from that side, is going to the right side. When the superior oblique palsy, the muscle paralysis is the side of the arrow pointing to that. Doesn't matter. After the end of this talk, I will show the picture once again. Now, what happens external in the here our patient had a left inferior rectus weakness. Now, the left inferior rectus is causing the false image below and up to the right side. Why this is occurring? Left inferior rectus is an extorter. Extorter means what? When that extorter is paralyzed, the eye turn inward. Okay, the image is turned outward, again in the same direction as the superior oblique. So that is why the arrow pointing to one side may indicate that either it is a superior oblique on that side or it's yoke muscle on the contractile side. That is why the arrow is pointing to the right side. Okay. If it is not clear, I will at the end I'll close this thing. The last 5 minutes, of course, I'll show the correct how this is produced later. But another picture which I did not bring it now. Right superior person. This is the one it's already told. Now, this is all. Forget about all those things. So you understood why the arrow is pointing right side in contralateral inferior rectus.
Yes, sir.
Yeah. Because
Yes.
say
This arrow is drawn in the offended position, sir.
yeah.
Offending position. The maximum diplopia position.
Maximum diploid, correct. Maximum diploid position. So what you do is suppose you find extraocular muscle normal. The patient comes with vertical diplopia and one image is tilted. Almost invariably, more likely it is superior oblique. This kind of a picture is very uncommon, which I have shown now. In that case, what you do is just draw a line on a piece of paper. This is what I have done. And bring that paper in the position of a maximum diplopia, what you see. So what I have done in this patient is that for the drain, I put him where the maximum diplopia is looking down onto the left side. Then ask him to draw the arrow, the false image. That is how you draw the false image. It is pointing towards the right side, going up. That means that usually indicates superior oblique, but here it is indicating a left inferior rectus. So what you do normally is draw a line, bring that line down onto the right, down and down onto the left side. He will tell you where it is maximally separated. Then you say you draw the line, how you see the line. He will draw the line with one straight, one angulated one. The angulated one going up towards the to form an arrow. The pointing arrow, the direction with the arrow points show the site of the superior oblique palsy. The arrow is pointing to the right side, right superior oblique. If the arrow is pointing to the left side, left superior oblique. That's a simple, easy method of diagnosing superior oblique. But what I have offered here, the explanation why it is pointing to the right side. This is because of the torsional movement or the overaction, because of the paralysis of the intorsion, the eye goes into extorsion. That is why this image is behaving like that. Okay. Don't worry, I will explain it later on little after. Or otherwise, the next class I will explain it with little more diagrams. Now this is. Shall I go to the next case? Okay.
Yes, sir.
Okay.
Okay, sir.
Now, this gets to Dr. Rajesh, who is we are working together in Travancore Medicity. This is a story of a 50-year-old man. His complaints first started 2.5 years back, as buckling of both knees while walking and mild difficulty in taking steps with both feet. From the very beginning, the story is a little confusing. Sometimes he will say like that, sometimes not very clearly, it does not give a history. Every time I have to ask him, what do you want me to be that? But this is roughly the history I got. Along with that, he also noticed lower backache. His lower backache improved with treatment, but the walking difficulty did not improve. For the last 1 year, that is 1.5 years later, he noticed difficulty to lift up his left leg when he was trying to climb onto the bus, and he had to take the support of right hand to lift up his left leg. That is what he said. For the last 6 months, he noticed numbness of both feet, which was remaining like that without any progression, only connected to the sole. His difficulty in walking remained like that for the next 8 months. 4 months back, when he tried to get up from his stool, he again developed lower backache, which subsided after 1 week. There was no root pain at that time. When asking his wife was noticed that his mild walking difficulty there for the last 6 years. These are all leading questions. I am getting it. I do not know if it's genuine or not. This is what wife told. He says he said he was all right. So going back to the history once again. The first complaint was 2.5 years back, is buckling of both knee. Then he had some backache, but that improved in between treatment. Then he noticed difficulty to lift up his left leg, and he has to get the support of the right hand to put the leg onto the board or to the bus. For the last 6 months, he noticed numbness of the feet, and then developed 4 months back again, developed backache, which then subsided. And wife noticed some walking difficulty for the last 6 months. This is the story. Such cases we have to believe mainly on the findings rather than this thing. So let the finding go to the findings now. Relax. Tone in the upper limbs are normal. He had no complaint in the upper limb dexterity. Willpower. Deltoid normal, biceps normal, no fingernails incoordination. So the lower limb he has no beaver sign. It is the lower limb. Inflection was normal, almost normal. The extension was normal. The smile weakness is there, not very sure about it. Perception was normal. Bedside examination, ETL was normal. Appeared normal. We like this ankle weakness is a hip flexion. It can easily break hip flexion. So actually the question is bilaterally weak. Bilaterally weak hip flexion. Biceps supinated check were normal. These are all normal. Imperfection I could not elicit. Ejects the wrist bilaterally. And Vijay was normally elicited, slightly controlled good, slightly compared to the upper limb, but compared to the knee, it is less. And there was upgoing bilateral. That was upgoing. This sensation was normal throughout.
അറിയാലോ ഇങ്ങനെ ഞാൻ കുത്തി വരുമ്പോഴേ
There's no sensory level anywhere.
ഇതൊക്കെ ഒരേപോലെയാണോ
These are almost normal.
ശ്രദ്ധിച്ചാണേ
Vibration normal.
ഇതറിയാം ഇതോ ഇതോ ഇത് ഇത്
Is it normal?
No.
Yes. Able to feel vibration all throughout.
ശരി എങ്ങോട്ടാക്കി എന്ന് പറയണേ
Once it's just the upper limb,
ഇപ്പോഴോ ഇപ്പോഴും
lower limb we made mistake.
ഇപ്പോഴേ അറിഞ്ഞൂടെങ്കിൽ അറിഞ്ഞൂടെന്ന് പറഞ്ഞാൽ മതി
He said he does not know.
ഇപ്പോഴോ
He made mistake.
അറിഞ്ഞൂടാ ശരി എഴുന്നേറ്റോ
Then Romberg's very positive, not very sure. Normal, almost normal. The way he walked, when he has to stand on heel, he could stand on heel, but when walking, the forefoot comes down a little bit. When walking on toes, again, one can stand, but when walking, the heel comes down. On both sides, more on the right side. Mainly on the right side is coming down. So on examination, tone, mild, mild spasticity of both the lower limbs, power upper limbs normal, lower limb, mild weakness of both hip flexors. Other muscles appeared normal when examined at the bed. DTR of both upper limbs all normal, both the lower limb knee jerks brisk, ankle jerk normal, abdominal reflex normal, plantas both upgoing. Sensory system, touch pain normal in both upper and lower limbs, vibration normal in upper and lower limbs, JPS normal in the upper limb, impaired over both great toes. Stance normal, Romberg's test very positive. Gait on walking is working on toes. His right forefoot does not, working on heel. His right forefoot does not extend fully on heel walking. And his heel sags down on walking on toes. That you saw that one. Not fully extending on the forefoot, not extending on walking on heel. And walking on toes, the right heel comes down on walking. But he could stand on toes and stand on heel. So, what is your localization this patient?
Sir, abdominal reflexes, sir?
It is elicitable. It is not
Above elbow.
it is just elicitable. It is still elicitable, not absent altogether. But not a brisk abdomen.
Sensory normal.
Sensory was impaired JP sensation over both the toes. That is, he does not know. All other sensations were known.
So hip abduction, sir?
Hip abduction, that's not let you know later on. Okay, I will examine it later. So this is the initial examination findings.
So UMN findings.
Yeah.
And there are element findings also.
Why element finding?
Because his own toe walking, his heels sags down.
That's correct. That's an important point. Heel sags down, but dorsiflexion also is weak.
That may be due to pyramidal weakness.
That alone you cannot say. No? You need pyramidal weakness. Only thing is relative weakness. If dorsiflexion is more weak than the plantar flexion, you can go with pyramidal. If plantar flexion is more weak than the dorsal flexion, that indicates LMN. Okay, you have got a good point. That's if it plantar flexion appeared likely more weak, so it could be an LMN associated with that. But that angle are very elicitable.
There are predominantly your motor, upper motor signs in low limbs with the involvement of dorsal columns, a suggestion of some dorsal column involvement.
Yeah, because of the JPS is absent on the feet also. Okay.
So myelopathy is the first possibility, sir.
Okay, very good. So that's the thing which I also thought. In fact, he was investigated elsewhere with some thought in some lumbar spine and all. Now, this is the thing. So, what investigation do you need? So, naturally, MRI of the dorsal spine, cervical spine, but he came with these investigations. This is the picture he brought. Cervical spine, only one picture is with him. This is the dorsal cord. This is also brought by him. This is the lumbar MRI. Sagittal cut, but its axial cut around mainly confined to the lumbar region. This is the D2 L1 level. This is L1 L2, L2 3, L3 L4. That level is not marked. Then L4 L5, L4 L5 lower part, then L5 S1. There is L5 S1 lower part. There appears to be some disc here.
The dorsal MRI not.
Pardon?
Dorsal spine MRI not is available.
Yeah. Axial cut, no? A dorsal MRI is the one which is brought by the patient is showing this is the dorsal. But there was no axial cut, only lumbar axial cut were available. So what do you want me to do?
The dorsal.
Yeah.
Repeat MRI, sir.
Repeat.
When was the MRI done, sir?
The MRI was done elsewhere because when I saw the patient in column, this is already
No,
done.
when it was done, sir? Gap 1 year back, 6 months back.
No, this was done about 2 months back. Just 2 months back. 1 year back is the story. 2 months back is when the MRI done. 2 months back, prior to my seeing the patient. So repeat MRI with proper thoracic and cervical region with axial cut. That is the thing wanted. So I repeated the MRI here. Sagittal cut. That is sagittal dorsal. Then this is a dorsal T2 axial. Then again, I wanted a thin cut to be like a thin cut of the dorsal axial. Again, no abnormality was seen. Then what else you need? Contrast?
Yes, sir.
Okay. So cervical spine contrast. Cervical and dorsal spine contrast is done. First enhancement with the cervical dorsal region, the upper also no one. This is an axial contrast. I think that should be not really, but there's enhancement. So normal now. What do you want?
Sir, any fasciculations are there, sir?
No fasciculations, no fasciculations. But you had impaired JP sensation. No fasciculation.
Homocysteine cortisol level, sir.
Homocysteine was not done.
What is brain done?
Stem, brain stem.
Brain I did not do, but I do brain for you. Do you think these when could be in the parasitical area? But the APS is affected both lower limb, both toes, no? Is it not out for a parasitical area?
Sir, B12 level, sir.
Yeah, B12 should be done. Correct. That is correct. Right. But I did not do that. The reason I'll tell you later on.
Sir, but the gait doesn't look like a spastic gait. No? So some abnormality is there in the gaits.
Correct. That is the point.
Sir, there was a lurching gait, no, sir. Looks like a.
Okay, that's the thing. That's the thing you have to find out. See, this even the reflex brisk. See, initially, first possibility, even though gait was not typical of spasticity, we think hard signs are the brisk. Knee jerk is brisk, and knee jerk will sit in the presence of a decreased upper limb reflexes, upper gland, and actually one thing of a myelopathy only. That is what I also thought. So then, when the MRI is normal, then I see even the very beginning I had this doubt. The gait is not look a spastic gait. Let's give the weight 1 second. Again, I check the finding of the second again. This flexion is able to walk, but the dorsal is coming a little bit. When walking on toes, right leg is coming down much more than the dorsal flexion. As already pointed by the previous. Okay, now what do you think now? What do you think about the gait?
Gait is due to plantar flexion weakness.
Maybe proximal weakness, sir.
In plantar flexion weakness, mild waddling is there, but more importantly, one finding which I'll tell you, if it is a plantar flexion weakness, the knee goes into flexion. Okay, plantar flexion is weak. Okay,
So the pelvic drop is there, sir.
Yeah, there is no actual pelvic drop. I'll show the. So examining once again in detail.
Knee goes into flexion while walking, sir.
No, not flexion. I'll show you once again. Now look at. So examining once again, seeing that finding. I'll show the what the finding later on. I think I'll show that video first again. Sorry. Look at what examine these quadriceps. Putting our weight on the right side, able to get up. Okay, now putting the weight on the left side, he could get up. So which muscle is weak now? Right quadriceps is weak.
Right quadriceps.
Right quadriceps is weak. Check the gait. Then look at the gait now. What is that? Look at the right and the left side. The right knee goes into hyperextension. Okay, going back, not flexing. See that? The
Yes,
right
sir.
knee is going back. Hyperextending. That indicates what? See that it's going backward, right? Concentrate only in the right knee.
Quadriceps weakness is locking.
That's indicated. Then the knee hyperextension is because of the quadriceps weakness. That clearly tells you this patient has got an element lesion there. This cannot occur with the UMN lesion. Okay, because quadriceps, the last muscle to become weak in bipedal. In the person related to normal dorsiflexion, this kind of cannot occur. Definitely, even the right knee jerk is brisk. See, knee jerk is brisk. Has got element lesion there. Now started examining him in detail in all the usual.
Sir, one doubt.
Yeah, please.
Quadriceps muscle is the last muscle to get weak.
In pyramidal lesion. In pyramidal lesion.
Okay, sir.
The point I'm telling is because the corticeps weakness in the presence of relatively normal dorsal flexion and all indicate an associated element weight. Now examine the prone position. Look at the right and the left. Extended like this is normal bilateral. Then examine the gluteus maximus. That is left side. That is normal on the left side. That is right side. That is weak. Left normal.
That is good power.
Again the right side. That is weak. I could easily overcome that. Okay. Then examine the abduction. That is on the normal side. Normal. That's the right side. That is weak. This is already I showed you. Okay. So what now? Examine what do you find? Weakness of both hip flexors, weakness of right quadriceps, Corey might be left quad. That's not very sure about it. Hip extension is weak on the right side. Like glutissum is weak, left is normal. Hamstrings normal. Why normal? Because keeping it extended, I cannot break. Hip abduction is weak on the right side, normal on the left side. That is why it's mild. Where somebody picked up mild waddling, it is there, but that is because on the gluteus medius and medius because on the right side, not on the left side. But his complaint was all on the left side. He said, you know, he unable to lift up his left leg, you have to put the right. That's not what he said. And right dorsal plantar flexus is weak, but more weakness on the right plantar flexus, not on the dorsal flexus. So right knee goes into hyperextension, but it's more weak than so such associated elements. So what is the possibility now?
Anti-dorsal.
Disease.
Anti-dorsal is got impaired JP. I mean, anti-dorsal mean what?
So myeloradiculopathy, sir.
Yeah, because sensory loss is there, not JP sensory loss is there.
That is on the finger, toes only, no? Sir?
Only on the toes. So in
But
fact,
it could be physiological, like his ages.
no, that cannot be physiological. See, how can JPs be absent in the both the toes?
In elderly, you may get.
And the usually vibration can be lost. Here, vibration is telling us correctly, but JPs.
Okay.
No, we have got important because this is a second examination I am doing. Even in fact, I examined even earlier column. That also it was impaired in JPs. The second exam when I brought him down to my hospital here, there again JPs was impaired. It may be functional, as you said, is correct. You may be not telling it correctly, but with the available finding, we cannot ignore that finding. We can disprove later on. So, what possibility will you consider now?
So one doubt, sir.
Yeah, please.
Sir, getting up from chair on one leg indicates proximal hip weakness or quadriceps weakness, sir.
Corticeps weakness. Actually, what we are trying to do is we are putting weight and extend the trunk with that, extend the knee, the whole body weight on that. Okay, you're extending the body weight, whole body on the corticeps on one side. You understood? If you want to see, yeah. But what we are trying, yeah, please.
This patient with hip flexion with the knee extended is relatively normal, but with the knee flex it is weak. Is it so?
Hip extension, correct. Why I'm telling is because
not hip extension, knee hip flexion. Flexion with the knee extended, as we usually examine, it looks normal, but it's very weak when hip flexion is examined with the knee flexed.
Yeah. In fact, you mean you are checking you are talking about the hip flexion?
Flexion.
Hip flexion. Hip flexion, what is the ideal way is when you ask the patient to extend it straight up like that, it is not only the hip flexion, other muscles also come into play producing hip flexion. For example, quadriceps also is a good hip flexor. So what ideally you to nullify the action of the rectus femoris, you ask the patient lie supine position, flex the knee as I have done here, and then break. That will check the true hip flexion. If we keep the knee extended and check the flexion, it is not only the hip flexes, but also the cortices part also will come into play.
Okay,
You got the
thanks.
point. So when you flex the knee, the quadriceps is nullified because that is relaxed, the knee nullified. Rectus femoris cannot act as a hip flexor.
Okay, sir.
Now, what possibility now? He has got element findings and he has got pyramidal findings with some sensory findings. Yeah, it's not like a peripheral neuropathy pattern is not there. See, he has got a hip extension, extension is weak, flexion is weak, abduction is weak, mild weakness, some kind of a not fitting with the typical peripheral neuropathy of a subacute combined degeneration. That is why B12 was asymmetrical also, grossly asymmetrical.
What is the evidence from the pyramidal side?
Pyramidal has got upgoing plantar, bisque knee jerk. Plantar is definitely employing. You saw the plantar. And knee jerk, which even though the muscle is weak, that jerk is brisk. Compared to the upper limb, the upper limb is a normal, sluggish normal power.
Sir, if the muscle is weak and the power is, the reflex is exaggerated, does it indicate anterior muscle disease or, motor neuron disease?
No, that what you said is correct. If you got a wasted, not weak, weakness can occur pyramidal lesion also. If it's got element findings and discrete pyramidal findings, the same thing, you have to suspect an antecondylar disease. What I said is correct. But that antecondylar disease diagnosis should be when you exclude other possibilities. Here, there is no sensory affected. Otherwise, agree with this antecondylar disease. Very much likely. But JPS is absent. Okay, let us see. You have to believe the patient, no? So, did the possibility, what do you possibly consider? I thought we
arachnoiditis.
Arachnoiditis is one, and dural AVF is another, because in between you were static, you were telling like that. So, I kept these two possibilities. My first possibility was dural AVF. That's what I thought. So, what do you want now? So, for the ideal sequence for dural AVF, cis sequence, some other sequence they were telling, if it is not 6, that is high T2, where you can clearly make out the CS. So, that was done on my insistence. This is a T1, this is not the picture. And that is a cis sequence. There is no vessel at all. There is no evidence of dural AVF. And usually dural produce some congestion of the cord, that is also. So, no dural AVF. Let's see the MRI of the spine once again, whether it could be arachnoiditis or not. So, this is a T2 MRI lumbar spine. If you look at the cord, that's cord icona, it's all clumped together. See? It's not like a separate one. Looks like a clump together. Also, one more picture. Yes, you look at the roots. It is not like a usual cord icona which you see. This axial cut. It's a dorsal. So that's only dorsal, sorry. Not. So there is clumping of the roots could be seen there. Now what do you want? Axial cut. So axial cut was taken. Here there is no clumping at all. The roots are all well separated. There is no evidence of direct clumping of the roots seen. There some suggestion of a clumping is the lower part. In between there is clumping, otherwise roots are also. Did you make out that thing? I'll tell you. Here the roots are separate, not even to say arachnoiditis. Now come down like some areas it's come. Again separate. Now it has become clumped together. That these areas, these two areas. That areas. So what do you want now?
CSF.
CSF. Before that,
Contrast study. Contrast.
Correct. The study of the lumbar region. This is the contrast study. There is no enhancement of the roots. So the diagnosis of arachnoiditis again very doubtful. This is axial, lumbar axial again, no enhancement of the roots. And you did subtraction image also find contrast. This is cervical subtraction, no enhancement. Dorsal subtraction, no enhancement. Lumbar subtraction, no enhancement.
What's the subtraction?
Subtraction means you take the contrast and subtract the T1 images from that. So you got only the contrast enhanced part will be seen. Sometimes fat and everything will also will appear and hyperdense in T1. Contrast also will appear as hyperdense. Okay, so you do not know which is actually fat or something like that. In that case, if you subtract the images, I mean all the T1 is there, that is subtracted. Only the contrast part is seen. So you can take
That can be.
Pardon?
That can be done by our SADA MRI or
No, SADA MRI. SADA MRI can be done. 1 point per test MRI can be done. But you have to ask for that. Now, the advantage in my hospital is that they will do whatever sequence I want. But you go and insist on them. So how many times these patients get brought back and into the consult? Some days 4 or 5 times I have made the patient lie on the consult to get the whatever we suspect. Because we are not getting a proper diagnosis. No, we are all confused as to what this case is. And this is all done free after one MRI they have to pay. All other things I'll ask them to waive off the fees. Okay, so arachnoiditis is unlikely. Now what will you do? Where are you now?
Sir, we'll do NCS to look for snaps.
Yeah, right. Then before that, you don't want CSF also?
CSF.
Yeah, CSF. CSF is normal. 33 protein, no cells.
Now we can do nerve conduction.
Okay, nerve conduction. Now the question comes, is it MND? Again, strongest point is absent joint present cells. Okay. Now what is against MND? Yes, impaired JP sensation of both big toes. And let's find out what is the site. Now we know that he has got a sensory loss. So what is the site of the sensory loss? So we need investigation for that. So what investigation you want now?
NCS.
Yeah, NCS. Okay, NCS was done. The motor NCS normal. Amplitude is normal. Sensory potential is normal. FA latency normal.
So it's either a radiculopathy or sensations you can just leave out.
So it could be MND also, sir.
Yeah, it could be MND also.
It could be a muscle, sir. Muscle disease, sir.
Muscle?
Muscle disease, sir. Is it possible, sir?
No, he has got an upgoing plantar disc reflexes, sensory finding muscle disease cannot be explained. Anticoncept, of course, I can agree with you, provided JP sensation is not there. Can typically fit with the motor neuron disease. Okay,
Patient, we cannot rely on the patient because he may not be telling correctly.
Correct, a quote. You have to provide evidence. If you say patient is bluffing, you have to say provide evidence.
It's reflex, sir.
Yeah, that's correct. So there is a lesion. We know that there is no lesion in the peripheral nerve to account for his sensory loss. Because of JPs being a large fiber involvement, sensory potential should be absent if it is a peripheral distal to the ganglion. So proximal to the ganglion, still snap can be normal. It can be radiculopathy. Why radiculopathy is angle juxtal decreased, not absent, decreased compared to the knee juxt. So that's possibility for radiculopathy. So H reflex. H reflex normal bilateral.
SSCP.
Pardon?
SSCP.
Yeah, SSCP. Why do you want SSCP for?
Because central sensory conduction can be.
Perfect. Yeah, so we are now, that's what each step, peripheral part is, distal ganglion is out, proximal to the ganglion, outside within the root is out. Then it could be the posterior column. That can also produce invade JPS. Somebody considers subacute combination is a good possibility. Because myelopathy with posterior column aorta, that we can think that possibility. So SSCP was done. SSCP is normal.
EMG, sir.
Okay, EMG will do, but our idea is what is the sensory is the one which giving you all these problems, no?
Then it is functional if everything normal.
Re-examine the JPS.
Okay, so re-examine the patient. Perfect. So I did the NCS femoral also because that is the one which is affected. Its motor may be normal. You got a left sensory saphenous absent. That's nothing to do with our patient, maybe some technical fault. So examine the EMG of the corticeps. With the EMG, last time I told you there's no spontaneous activity. The last time I told you the early evidence of innovation. See the firing pattern. There is an increased improvement ratio. High potentials occurring in the screen without a second potential. That frequency is firing. That indicates an early denervation. As got an increased recurrence pattern. To compare with the left corticeps, so I want to know whether left cortex is affected or not. There was no increased firing rate, that is normal. No spontaneous activity. It's a normal pattern. From the very beginning, the pediatrics are happening. Not increased firing rate like the previous. They wanted to know whether it's denervation the right tibialis anterior also affected muscle in this patient. The tibialis anterior. Again, no spontaneous activity. The increased firing rate of the potential. That's it of innovation. Then mild decrease in recurrence pattern. Then did on the left side. No. There's no increased firing frequency. That is normal. Then find out motor neuron disease. You have to show more than one segment. So did from the upper limb to find out any PI. No spontaneous activity. Normal potential. So it shows early denervation, the right corticeps and right tibialis anterior. Left corticeps, left TA and FTA were normal. So is it MND now? I've got pyramidal signs and it's got denervation in the corticeps and this thing. All favoring MND, correct?
Probable.
Probable, correct. Only what is the thing which is standing our sensory, which we almost disproved that it is not functional because it is not in the nerve, it is not in the root, it is not in the posterior column. So, how to explain the absent JPS? We should examine it again.
Yeah.
He said correctly. Perfectly telling correctly. Initially, he said he did not know. And that is the story of the patient. So sensory system examination can be very some problematic because highly subjective. You have to believe what the patient says. In that situation, you have to go to such techniques to disprove what he is telling, just like the evidence is provided in the court. So that is why I brought this case to you. It's most likely an anticontinental disease, but it's not a very actively degenerating one. It's a slowly progressive type of motor neuron disease.
So he had to go through so much agony to find out the diagnosis.
That's why, neurology is like that. Sometimes we have to see these patients. I must have 1 week thinking about what is his problem. Why he's got nothing is fitting with. His human is not fitting with, LMN is not fitting with, combine is not fitting with. Then JPS is coming in the way. Then you have to disprove each and everything. Then I consider arachnoiditis, discuss the radiologist. He said arachnoiditis. Then he asked me to do the contrast. That is negative. CSF was done. That is negative. Initial picture was something like a myelopathy.
So then why he said the JPS was why impaired?
Frankly, if it had been a female patient, I would have diagnosed functionally very early. But such a person I never respected in that he will bluff. And even when examined it very straight away, said, I do not know, sir, where it is. Upper limb and all tell him very correctly, without any mistake. So I was
Usually in JP's examination, many patients says wrongly, but never says this not appreciated.
Yeah, correct. So that is how patient will fool you. So
Males also can bluff there.
Pardon?
That means males also can bluff.
Correct. Okay, you're right, Bindu. Okay, shall I show you next case?
Yes, sir.
Any questions in
Sir,
this case?
One doubt:
Yeah,
the
please.
initial case with inferior rectus palsy, any treatment was offered?
No, in fact, in fact, he was improving from the weakness. But since it's not totally improved, I did an MRI and CT or the orbital to find out any tethering. Tethering means the blowout fracture of the orbit, which can impinge onto the muscle and prevent the recovery. But that was not there. So in due course, he will improve.
Okay, thanks.
Whenever a person is not improving more than 3 months, always rule out in a person with fracture of the skull, the impingement of the muscle, producing a restriction of the restrictive myopathy. Okay, this is another good case. Not very good. Okay, good case. He is a 55-year-old man, non-case of diabetic for the last 25 years. He noticed difficulty in getting up sitting position for the last 3 years. History of buckling of the knee while climbing down the steps for the last 3 months. Low backache for the last 3 years. No root pain, no sensory complaint. So diabetic, notice difficulty in getting up sitting position for 3 years. Buckling of the knee while climbing down the stairs for 3 months. And low backache for 3 years. This is examination finding. Painless are all normal. Rattling movement, tongue movement were normal. There is no specific. He has a wasting of the arm. Could be seen. No wasting in the forearm and hands. Deltoid, not normally mildly weakness at deltoid was there. Biceps was weak. Biceps is normal. Recurrentialis is normal.
சரி நூறு படிங்க படிங்க கொக்குங்க
Finger extension is normal.
கடி மடக்கி படிங்க இது மடக்கி படிங்க கரெக்ட் நீங்கள் கோஆப்ரேட் பண்ணுங்க அப்படியே
Finger abductors are all normal.
ரெட்டில் தொட்டு மொக்கில் தொடுங்க
There is no finger loss in coordination.
மற்ற கை நேரம் கொக்குங்க
Look for any winging for the scapula. Deltoid is mainly weak. But he had wasting with the
லூஸாக
cortices.
போடணும் என்ன
One was hypotonic or normal tone.
பேக்வர்ட் வேட்டு
Is marked weakness like hip flexion. You cannot keep it against cavity at all.
இப்படி நிறுத்துங்க பார்ப்போம்
Easily I can overcome.
இங்க
The action is also weak
சவுட்டி மாற்றுங்க
and mildly weak.
இது சவுட்டி மாற்றுங்க சவுட்டி மாற்றுங்க மாற்றுங்க
Loose flexion was normal.
இது முள்ளட்டு பிடிங்க முள்ள பிடிங்க
ACL was normal.
நல்ல விட்டு கொக்கி பிடிங்க இது முள்ள பிடிங்க சவுட்டுங்க
Retropection normal.
சவுட்டுங்க 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 சரி காலணும்
Hip abduction normal.
நீ சேர்த்து வைங்க
Hip adduction normal.
சேர்த்து வைங்க போதும் விடுங்க
Plus upper limbs were normally elicited. Prices appeared mainly decreased. Finger pressure absent. Abdomen reflex was sluggish. It's absent. He just elicited, but it's one picture of movement I could get. Angle jacks are absent.
சுகர் இருக்கு அவங்களுக்கு
Diabetic. Under was indefinite.
இந்த குத்துதெல்லாம்
This is
தெரியுது
all
தொடுதெல்லாம் தெரியுதா இப்படி குத்தி வரும்போது வித்தியாசம் இருக்குன்னு சொல்லணும் இது தெரியுதா கிரிகிரிப்பு
Able to feel
இது
vibration.
தெரியுதுல்ல இது தெரியுதா
Yes, he is able to feel it and also
இப்போ
set correctly.
இப்போ 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 சரி எப்படி இந்த பண்ணி காணுங்க செஞ்சிருங்க
That's good to get up. You cannot get up on straight open position. Return to the side and get up. Painless normal. Motor system upper limbs, thinning of the both arms, tone normal. Power weakness of both deltoid and biceps. Why did I examine specifically for brachioradialis? Because biceps and brachioradialis play with the same root and segment. Here biceps is affected and the brachioradialis is not affected. That's not fitting with the root or segment. That's why I specifically look for that thing. Triceps, wrist muscles, small muscles are all normal. Lower limb, wasting of both thigh, weakness of both hip flexors and mild weakness of knee extensors. Rest of the muscles were normal in the lower limb. Detail all upper limbs are upper limb 1+. Lower limb knee jerk, just elicitable, not one, just elicitable. A flicker and both angle jacks were absent. Plantar normal, sense system normal. So what is the diagnosis? Or localization? Any clarification, please ask.
Pure motor,
Pure motor,
proximal,
proximal, correct.
hyperflexic,
Pardon?
hyperflexic,
Hyperreflexic. Almost absent, we can call it. In the lower limb.
CIDP,
Okay, CADP is a possibility, but only proximal, only distal is not affected that much. It's a possibility, can be ruled out, perfectly agree. But I think sensory is not there in this patient.
Diabetic amyotrophy.
Flexopathy.
Okay, diabetic flexopathy is a possibility. Diabetic amyotrophy is a possibility. Correct?
Myopathy or SMA?
Myopathy is also a possibility because a pure motor. So a pure motor means all these possibilities you have to keep in mind.
SMA
myopathy, motor CADP, or this thing, what do you call it? Anticonceptual disease, all you have to keep in mind. Okay, so what investigation you want first?
Sir, diabetic motor proximal neuropathy. Is there something like that?
Yeah,
Pure
yes,
motor.
diabetic proximal neuropathy. That is our neurologic hematrophy in diabetes, diabetic hematrophy.
And that is usually asymmetric. This
Yeah,
is symmetric.
No. It can be two types: DAM1 and DAM2. DAM means diabetic hematrophy 1, DAM2. The DAM2, you get a symmetrical involvement. They can present with a subacute progressive involvement without pain. The DAM1 is the one asymmetrical with pain and relatively good improvement. The second one is relatively, they can improve, but slowly progressive initially. The improvement is less obvious.
Which one is improving? Which one will improve symmetrical?
The type 1 is the one which was good improvement. With pain.
That is asymmetrical.
Asymmetrical one. Asymmetrical is the one with good improvement and with pain.
So the second one, DAM2, occurs with the long-standing diabetes, sir?
No, both are the same. That they're not specifying it. All describe type 2 diabetes more common than the type 1. But I don't know which long-standing, they're not mentioning it.
Okay.
So I thought first possibility could be a myopathy because limb girdle pattern involvement. Yeah. So what investigation you want now?
CPK.
CPK normal. 279.
And EMG.
I don't know, THT is just normal. This all came with that following MRI. The patient came with the following MRI. He came with an MRI. This is MRI. MRI hip girdle normal. So what else you need now?
EMGs.
You need to find out there is NCS can be done, EMG can be done. Okay, but I'll show you some other part of it. I did not do any of those things. The reason I'll tell you. There is some clue in the first examination, but I'll show you some part of the examination here. This is the part I examined. Start examining. I found some following in front of the delta. Did you see that? I asked him to remove the shirt and see what is that. What did you find? Did you some scapulars coming up?
Yes. Polyhedric.
What do you find there?
Yes, a transverse crease.
Yeah, there is a transverse crease, and one more thing. I'll tell you, scapula is coming up. Did you see that? See the scapula here?
Yes.
And the scapular hump is typical of FSHD, correct? Let us see what other examination I like to do. I'll show the exam. Yeah, I'll see the one more thing.
Beaver sign.
Beaver sign. Ask him to cough. See, the abdomen is moving up. Okay. Beaver sign, and look at it. Erectile is major weakness. And see the scapula come on the right side, asymmetrical.
Yes, sir.
Now my question is, scapula hump is due to what? Weakness of trapezius. But usually trapezius muscle weakness, what should happen? The scapula should move out, but it is moving inside. I'll show you once. I'll show once again. Sorry. See this one. If it trapezius weakness, the scapula should be moving out. Here the scapula is moving medially.
Serratus.
Serratus anterior can produce, if it is, weakness can produce medially. Okay, that's agreed. That's the lower angle will, here trapezius weakness is there. No, that is where the scapular hump is occurring. That is because the scapular hump is because what? The scapula has gone up. That means the inferior fibers are weak. Why there is no scapula not moving out? Because the middle fibers are intact. So that shows the peculiarity of the FSHD, where it selectively affects one part of the muscle. If you get biceps, sometimes only part of the biceps will be affected, hypertrophied part will be atrophied. So similarly here, the inferior part is profoundly affected, that is scapula moves upward. And inferior muscular part is the other one which rotates the scapula also, for going in the abduction above 90 degrees. The middle fibers retract the scapula. I'll explain a little bit later on. So that is why scapula moving like that. Okay. Then why is scapula gone medially? It should have been gone laterally. It's because the middle fibers trapezius is spared. What is the scapula? You can see the scapula occurring. This is because the elevation of the scapula due to weakness inferior fibers trapezius. Let me give you another clue in this patient. Now, what is this test which I am doing in? We asking to forward flexion, the whole trunk goes backward. We want that equal forward flexion is limited, so that is carried out by the scapular rotation, and the trunk goes backward to compensate that thing. That is called the trunk extension or active elevation sign. I will show that video. You can compare with the normal patient. This is normally one patient does. Because our patient's trunk is going to position. And one more sign in this particular patient, that is the beaver sign. Abdominal muscle is moving up. So diagnose facial scapulohumeral dystrophy. Now, what other examination like to do in this patient?
Facial.
Yeah, correct.
Facial weakness.
Correct. Facial weakness. I have to remember that just like our trapezius, one part may be affected. Here in FSHD, sometimes only lower lip fibers will be affected. Sometimes the upper part more will be affected. Sometimes only the orbicularis or will be affected. Some frontalis alone may be affected. So you have to check each part of the muscle, not only from the front, from the side also. Why from the side? Because the lower part is affected, you get the called classical tapir nose appearance. The upper lip will come forward, the lower lip will not. Something like a tapir, the animal's snout. That is a typical described in FSHD. So examined for the facial muscle weakness. No more facial weakness.
Correct.
They are not tapir nose, nothing. So the facial scapulohumeral now. It's not facial. Yes, it can be. In facial scapulohumeral dystrophy, the percentage can be so varied. Some of the muscle may be spared. I have seen FSHD presenting with a foot drop, acute foot drop. So that sometimes presenting with a brachial neuritis like presentation can occur with FSHD. Okay, now you want to confirm the diagnosis. What will you do now?
Genetic study, sir.
Genetic study, but you know, the test is not the conventional clinical exam. Then one test is there which is very not done routinely and very costly also. It amounts to about 80,000 to 80,000 rupees.
Muscle waves.
Pardon?
Muscle waves.
Muscle waves is not going to give any diagnostic clue. Only shows dystrophy. EMG also tell you it's a myopathy.
Family history, sir.
Correct. In family history. So a patient didn't have any family history of the similar illness. What will you do?
Check the family.
Check the family members. Photo.
Correct. Check the family points. So the one brother was staying in Chennai, the other fellow was in Bangalore. There's two, but he is the eldest one, this particular person. Two younger siblings. One is in Chennai and one in this thing. Then I know what I did. I told the patient, you have to bring your relatives. Otherwise, you have to spend about 80,000 rupees. What do you want? Then he said, you bring the relatives. So after 1 week, he brought both the brothers. Both were males, index patient the eldest. So the youngest brother I examined, this youngest brother,
കൈ മൂത്ത് വീങ്ക.
Yes, normal, no abnormality.
കൈ മടക്കുങ്ക. ഇത് മടക്കുങ്ക. ശരി. തിരിച്ചാണ്. ഒരു നിമിഷം
Scapular winging, nothing.
കൈ താത്തുവാങ്ക.
It's no that that particular sign was negative in him.
ശരി പോകും.
He would walk on, stand on heel.
ഒരു നിമിഷം മടക്കുങ്ക.
Yes, no reverse sign. So it's normal.
മടക്കുങ്ക.
His youngest. Examine the second brother. The muscles are all normal. Pectoralis major normal. Yes, is it normal according to you? Has he got a scapular hump? There?
Yes, sir.
Not very convincing, no? Suspicion. Yes, no, that active elevation sign is negative. Would indicate trapezius muscle weakness. Right, with Beaver's sign, is no Beaver's sign, but he has got an abdominal hernia. Random hernia is there on the left side, bulging in. Reflexes are all normal. So, is it FSHD now?
Hernias also commonly seen in FSHD.
But
Hernias also can be seen in FSHD.
exactly, because the asymmetry is one of the classical finding in FSHD. It's one myopathy where asymmetry is very, very common. So what else I did do? It's also normal. This is the abnormality in this picture. Okay, further examination. On examination, I will show you. Random hernia is there on the left side, not on the right side. Then asked him to get up from the lying down position. He could not get up. He could not get up from the lying down position at all. The supine position. He's trying his level best. Examine the pectoralis major, that is okay, normal. So his only muscle weakness was abdominal muscle, which is asymmetrical, he don't get up in squatting position, and only one scapular hump with a little normal power of the trapezius. No Beaver's sign. So I note asymmetrical, but the abdominal wall, you cannot get on the position. So examine second sibling was affected. To find out whether the first sibling also had difficulty getting up, he was examined once again, he had put to bed again. So I examined him, the youngest. He could easily get up. Without any problem. The second one could not get up.
There one doubt.
Yeah.
The second one and the first one, no, he has got a abdomen is little bit big abdomen. So will that if he is not used to getting up just like that, so
Yeah,
can it be?
Yeah, yes, perfectly right. It means somebody, even normal people, someday they cannot get up in the supine position. No. But the problem, what you said is exactly correct. But the fact here is that this fellow is also the same size. This is the youngest fellow. The other one is the second brother. Both of them have got the same physique. And this fellow could get up easily, the other he could not get up. Moreover, there was an abdominal hernia in the second person who cannot get up.
Yes.
He did not have that thing. And the scapular hump was also for the second brother. He did not have that.
Yes, sir.
So putting it all together, most likely this thing. So I'll show one more, just finding this, which I think we'll skip all this theory part of it. This is called the sign which I'll show. This is the thing which I already told you. The upper fibers elevates, middle fibers retracts, and the lower fibers depresses. The middle and lower fibers appears to play a major role in stabilizing the scapula medial body during resisted humeral rotation. Okay, then this is called active elevation lag sign. The active elevation lag sign is used to detect trapezius muscle dysfunction or spinal accessory nerve palsy. To perform this test, ask the patient to forward flex her arm at the shoulder on the unaffected side. Next, ask the patient to forward flex arm on the shoulder on the affected side. If there is no difference, no lag, the test is normal. If there is observable lag between the affected and unaffected side, the test is positive. Alternatively, the patient's hyperextension is tracked back, just like what you see here. Now it's going backward. To compensate for the lag, the test is positive. That is what is positive in our patient. This video is from the YouTube. I will show you the
is used to detect trapezius muscle dysfunction or spinal accessory nerve palsy. To perform this test, ask the patient to forward flex her arm at the shoulder on the unaffected side. Next, ask her to forward flex her arm at the shoulder on the affected side. If there is no difference or no lag, the test is normal. If there is an observable lag between the affected and unaffected arms, the test is positive. Alternatively, if the patient hyperextends her back to compensate for the lag, the test is positive.
Okay, that's the story of the patient. I find this is a very useful find test add, and the previously also it showed one case of FSHD where this particular sign is very strongly positive. This active elevation arm sign. That very easy to examine also. As you lift up, the tongue goes backward.
Sir, since there is discussion of medial upper and lower fibers of trapezius, lipid cut examination, muscle examination depicts three methods for this examination of trapezius, sir.
Correct,
For lower fibers. Yeah. For second, brother, we can try that. We can prove the grading with grading of power. We can do that, sir.
No, grading the power with trapezius, I don't know. It is possible. Very difficult.
Okay, sir.
But look at if the patient's the shoulder shrugging is normal, the upper fibers are normal. The scapula moves upward, hump is there, lower fibers are weak. The scapular rotation is affected, lower fibers and middle fibers are weak. The retraction is affected, middle fibers are weak. The scapula moves outward. That way you can pick out the abnormalities.
Regarding the active
Lag sign.
Sorry. I'll stop. Yeah, please.
Sir, if there is active forward flexion and the trunk is hyperextended, so what does that indicate, sir? Where is the weakness?
Indicate the weakness is that the patient is unable to lift up here and produce a complete forward flexion. Because if you make it beyond 90 degrees, the flexion part is done by the rotation of the scapula forward. The rotation is carried out with the trapezius and the serratus anterior. The patient cannot elevate the arm beyond 90 degrees. So what is the patient asked to elevate? He has to necessarily extend the tongue backward to bring the arms upward. That is why he is doing this sign. Because that the video part, I will show that is very clearly seen in this particular patient. Beyond 90 degrees, he could not elevate the shoulder, the arm. Instead, he is trying to compensate by extending the trunk. Okay, he is compensating by that. He is trying to bring the arm upward, not possible. So he is trying to extend the trunk backward.
Okay, sir. Sir, one more thing, sir. There are three types of scapular winging, sir. That's serratus anterior. Can you just tell me rhomboids and trapezius difference, sir?
Okay. In the next class, I will show each video of each one I'll show, but now I'll tell you the mechanism is everything. Now, first look at the position of the scapula. In the case of trapezius muscle weakness, the scapula will move out on the midline. So the distance between the spinous process and the medial border scapula is more on the affected side compared to the normal side. And the scapula which is going to wing is the upper angle of the scapula, upper part of the scapula will wing. So that is the increased distance between the midline and the upper angle of the scapula, spine of the scapula on the affected side compared to the normal side. Now, to make it more prominent, the easy thing is that if you suspect one muscle is weak, they put that muscle into action. So you put the trapezius into action, the winging will become more prominent if trapezius is the culprit. So in such a situation, what do you find? The scapula is moved outward, or you not see moving outward, make the muscle into action. Trapeze is not acting mean, the other muscle is acting mean, it will pull out the scapula further anteriorly. So if the patient would abduct the arm, the winging become more prominent in the sense that the affected side, the scapula will move outward, and the distance between the spinous process and the upper angle of the spinal scapula increases. That is the classical winging of the scapula seen in trapezius muscle weakness. In the case of serratus, and that second muscle, serratus anterior. Serratus anterior is actually coming from where? From the anterior part of the chest, going backward and inserted into the medial border of the scapula, maximum in the inferior angle of the scapula. The maximum bulk is in the inferior angle. So that muscle is protract your scapula, pushing your scapula forward. So if that muscle is paralyzed, what happens? The scapula will go medially. So instead of forward, it go backward. That towards the midline it will go. So here the scapular winging is the medial border will move towards the spine. Whereas trapezius, it moves away from the spine. Here the lower, especially whole medial border, especially the inferior angle, will move medially. Now, to make it obvious, what will you do? Ask the push against the wall. That means you're putting the serratus anterior into contraction, acting from midstation to origin. So this winging become more prominent. Okay, more prominent. That will make the serratus anterior winging more prominent. In rhomboids, what happened means that just like trapezius, the trapeze fibers arising in the midline, spinous process to the middle part of the scapula. Rhomboids also does the same thing, but the direction of fibers is different. In rhomboids, the fibers go down and laterally. Where middle fibers go up and laterally, here it go down and laterally. It again inserted into the inferior angle of the scapula. So you do the rhombus testing. Here, the inferior angle will move laterally because the fibers are coming from the midline to lateral, just like trapezius. So the fibers, the scapula will move laterally, and the angle which is going to wing is the inferior angle because the rhombus is inside of the inferior angle. Okay, and so in a nutshell, in the case of trapezius winging, the upper angle will wing and will move away from the scapula. And it made prominent by asking the patient to abduction movement. In rhomboids weakness, again the scapula will move away from the spine, but here the lower angle will wing, and it is made prominent by asking them to do the rhomboids muscle testing and pushing backward in the abduction position. In the case of serratus anterior weakness, the scapula will move medially. The other two will move laterally. Here the scapula will move medially towards the spine. And that wing will be more on the inferior angle, and then be made more prominent, pushing against the wall. Is it clear? Is it clear to you now?
Yes, sir.
Next time, no, I will show all the video of all the three muscle weakness, which I have with me. I'll show that thing, and I will also show that by that superior oblique and everything. I'll do next class. How that this is produced. Okay, then shall we close now?
Thank you, sir. Good night, sir.
Thank you. Thank you. Good night.
Thank you so much, sir. Thank you so much, sir.
Thank you, sir.
Thank you, sir.